osteopathic manipulation, and the healing arts. He's a graduate of the Arizona College of Osteopathic Medicine, which makes me feel old because there didn't used to be one when I was in med school, and completed an osteopathic internship at Maine, Dartmouth, and Augusta. Dr. Sulak has been incorporating cannabinoid therapies into his integrative practice since 2009 and has lectured on the topic extensively. He's the first physician on the East Coast certified as a diplomat of the American Academy of Cannabinoid Medicine. He practices in Hallowell at Maine Integrative Healthcare and in Falmouth at Integrate Health, LLC, and has now moved to Manchester, yes? Manchester? Okay. Hallowell, yes. Hallowell just up and moved. It just moved right over. So please welcome Dr. Sulak as he speaks about vitamin D.
Hello. All right, thank you all for having me. I'm really happy to be back. It's an honor and a pleasure to speak to you and to have the chance to talk about some therapies that I found very effective in my practice. It's so satisfying when we can find simple ways to really help people improve their health and improve the quality of their lives. And today it's my great honor to talk to you about vitamin D. Let's see. Can you hear me okay when I'm remote? That seems like that's working. So an overview of our talk today. We'll start with an introduction and a brief history of vitamin D, which is quite interesting. We'll review vitamin D physiology, and then just kind of look over some of the old news, which might be new news to some of you, some of the major correlations and findings, reviews of vitamin D. And then sticking to the title of this lecture, Vitamin D Update, we're going to focus mostly on new vitamin D studies and information that has come out in the last year. And those selected topics are mortality, depression, pain, hepatitis C, respiratory infections, infant heart failure, lupus, and atopic dermatitis. So all things that we probably see a fair amount of in our practice, even though we have a diverse group here. Then we'll talk about the difference between vitamin D2 and D3, safety and toxicity of vitamin D, and I'll give you my recommendations for testing and supplementation. So thank you all for your attention while we enjoy our lunches here on this snowy day. Thanks for your attendance and presence. I have no conflicts of interest or financial relationships with vitamin D. Nobody does because it's a bioidentical natural substance that cannot be patented. Integrative medicine is something that I've been practicing for a few years now. And it's a framework, a methodology of addressing patients as individuals, taking into account body, mind, spirit, community, all the aspects of holism in each of our patients. Integrative medicine has an emphasis on prevention, an emphasis on safe, natural, and less invasive therapies whenever possible, an emphasis on mind-body connection. In the work of integrative medicine, I've come to realize that each of our patients is an individual and requires an individually tailored treatment plan and treatment approach, and therapeutic relationship that's individualized. Yet in that work, I've started to discover certain compounds, certain substances that are paradoxically applicable to almost all of my patients, and that can help the health of almost everyone. And so there's this individualized approach, but then there's this question of, are some of these substances almost panacea-like? And to me, what helped me solve that difference, that paradox, are these wise words from A.T. Still, that man should study and use the drugs compounded in his own body. And I think that when we focus on this in terms of our pharmacology and our supplemental approaches to health, we find substances that have a wide variety of applications and a very good range of safety and biological, physiological effects. So let's take a look at history of vitamin D. In the mid-1600s, rickets was identified as a major health problem as people started to move to more urban areas. By the early 1800s, rickets was epidemic in Northern Europe and certain areas of the U.S., a major issue. In 1822, the first paper was published that observed that lack of sun exposure had something to do with rickets. And this was looking in pulling the difference in children that were urban and rural. In 1824, the first report on the use of cod liver oil to prevent rickets. And in 1992, McCollum coined the term vitamin D to describe this unknown anti-rickety factor in cod liver oil. Also, kind of on a parallel track of scientific inquiry, in 1922, the same year, the anti-rickety properties of ultraviolet light was demonstrated in rats. In 1927, Quaker Oats began manufacturing vitamin D-enriched cereals. Pharmaceutical companies began producing vitamin D2, irradiated ergosterol. In 1934, we started enriching milk with vitamin D, and rickets was quickly eradicated. So major success in public health in 1934. So again, this kind of parallel track of inquiry. Late 1800s, tuberculosis was a major issue, and the preferred treatment for TB was heliotherapy, which is sun exposure. And here we've got some cute pictures of bones in the sun. In the early 1900s, we were still treating TB with artificial sources of ultraviolet light. In 1903, Finson won the Nobel Prize for his machine that would treat lupus vulgaris with ultraviolet radiation, which is a skin tuberculosis infection. I found this article. A patient gave me an osteopathic journal from 1939 that he found in a drawer in an antique store, and it happened to have a vitamin D article in it, massive vitamin D therapy in arthritis, that basically describes using mega doses of vitamin D2 to treat rheumatoid arthritis. And then I include the current RDA numbers here in the historical section of this presentation, because truly that's what they are. We can see that the current RDAs for children and for adults and for pregnant women and lactating women are 600 IUs. That was just raised from 400 a couple of years ago. And the EAR, the estimated average requirement for all these groups, is 400. And the upper intake level is 4,000. So what's interesting and historical about these numbers is that 400 units of vitamin D is what is contained in 1 teaspoon of cod liver oil, the amount of cod liver oil needed to prevent rickets in children. And so that's where this number came from. 400 units per day was set before the discovery of the vitamin D blood test. And it really has, it's not consistent with the current evidence of how much vitamin D we need to be healthy. The 4,000 upper intake level was arbitrarily set at 10 times the previous recommended daily allowance. And there's, just a couple examples of conflicting evidence with the DRI recommendations. In this small study, 28 adults were given 4,000 units of vitamin D per day for 5 months. And their serum levels of vitamin D averaged 40 nanograms per milliliter, which is nice, but not a whole lot. And we'll talk a little bit later about what the different serum levels reflect in terms of health and physiology. Another study looked at 67 men given either 5,000 or 10,000 units a day for 20 weeks. And they also had safe serum levels of vitamin D. So I don't think that upper limit of 4,000 units in adults is correct from what we can tell. So let's talk a little bit about vitamin D physiology, beginning with how do we produce vitamin D naturally in our natural environment? Well, we have a secretion of 7-dehydrocholesterol from the glands in our skin. And when that, what's called a pro-hormone, is exposed to ultraviolet B radiation in this specific wavelength of 290 to 335 nanometers, it's converted quickly into pre-vitamin D. And then pre-vitamin D is converted just simply by the body heat into vitamin D3. Now, what's interesting to notice is that after you create pre-vitamin D or D3, if you get exposed to extra ultraviolet radiation, more than you need, you'll actually inactivate those vitamin D products. So basically, getting a nice tan, you're going to make a lot of vitamin D. Getting burned, you're probably not going to make much at all. And so looking a little bit closer at skin production of vitamin D, I was very impressed and surprised to find out that there's been a lot of scientific inquiry into this question here. Just some data I'll share with you. One minimal erythema dose, which is the dose of ultraviolet radiation that causes a person's skin to just become slightly pink, is equivalent to somewhere between 10 and 25,000 IUs of oral vitamin D intake. And the actual vitamin D that we produce in the skin is subject to many factors, including how high the sun is in the sky, the altitude that we're at, the atmospheric aerosols and the clouds, the surface reflection, whether we're on grass or sand or concrete, ozone on that particular day, of course your skin type, how dark your skin is, and your age and obesity can make a big difference in how much vitamin D we're able to produce. But the question I was asking is, how much vitamin D can we get from the sun here in Maine? And what's practical for us to, what's some information we can use to make recommendations to our patients? Also, it's important to note that sunblock significantly prevents vitamin D production. 92 to 95% is blocked with SPF 8, and it goes up from there. So a lot of information about these variables has been put into some really interesting online calculators that can help determine equivalent vitamin D production in the skin. And so I entered some variables. I entered for Portland, Maine, midday, so noontime sun on a day with moderate ozone. Fitzpatrick skin type 3, which is medium, white to light brown skin that sometimes gets a mild burn but gradually tans to a light brown. So kind of a middle-of-the-road skin type. 25% skin exposure, which would be wearing a t-shirt outside at sea level here in Portland. A cloudless sky with high visibility, maybe playing on the grass with a t-shirt on. So let's see how much vitamin D we would get if we had that skin type under those conditions. Exposure, so the required time under those conditions to produce the equivalent of taking 2,000 units of vitamin D3. Well, if we were out there today, if it was sunny and we were out there at noon, it would take us 57 minutes in a t-shirt to make 2,000 units of vitamin D. 2 months from now, it would take us 14 minutes. And 2 months from then, in June, it would take us 9 minutes. And I put the percentage of the minimal erythema dose on here. So it'd be half of what it would take to burn us to be out there today if we had this skin type. If we were trying to make 5,000 units of D3, which is probably what most of us adults would need, it would take significantly longer. It would not be possible today under those conditions that I put in. It would take 36 minutes in April, and it would take 23 minutes in June. And in April and June, we'd be coming a lot closer to sunburn. We'd be out there for 90 or 86% of our minimal erythema dose. So it is certainly possible in the summertime here to produce enough vitamin D, but not very possible in the winter. It's difficult in the late fall and in the early spring. So getting back to our physiology, once we produce vitamin D in our skin, or once we consume it as a supplement or in our diet, it enters into our circulation. It does get stored in adipose tissue, and through circulation, the vitamin D3 makes its way to the liver, where it's converted into 25-hydroxy vitamin D. If we consume D2 in fortified foods, we make 25-hydroxy vitamin D2. If it's D3 from our skin or from supplements, we make 25-hydroxy vitamin D3. Similar molecules, but they do have some differences that we'll talk about later. So the 25-hydroxy vitamin D is the storage form. It has a very long physiologic life in the body, and it's what we measure to determine somebody's vitamin D status. The 25-hydroxy vitamin D is converted by the kidneys into calcitriol, also known as 1,25-dihydroxy vitamin D. The calcitriol has numerous functions. We think mostly of the functions related to calcium homeostasis and bone remodeling. So the calcitriol will stimulate osteoblasts, which in turn stimulate osteoclasts to increase calcium resorption from the bone. It basically stimulates remodeling. The increased calcitriol will raise serum calcium, but at normal levels it stimulates both osteoblasts and osteoclasts, so it's a remodeling process. Calcitriol in the intestine will increase calcium absorption from the foods that we eat. Calcitriol in the kidneys, I'm not sure if it's shown here, but it increases calcium resorption from the urine. And all of this is directly related to parathyroid hormone levels, which increased parathyroid hormone levels will also increase the serum calcium. So those are some of the more well-known effects of calcitriol in the body as related to calcium homeostasis. Very important effects. And this is just a review of the various functions that I just mentioned. But what's interesting that's just come to light in the last 5 years or so is that calcitriol is, or maybe the last 10 years, calcitriol is not just active in the kidneys, it's not just active in calcium homeostasis. It's active all over the body. So our circulating storage form, the 25-hydroxy levels of vitamin D, are related to how much dietary intake and sun exposure we get. The calcitriol levels that are circulating in the serum are controlled by homeostasis. But the key finding here is that a whole variety of other tissues in the body are able to convert the storage form into calcitriol for very local tissue-specific functions. These are paracrine and intracrine functions, and these functions are diverse all over the body. So instead of just these effects in the kidneys that I mentioned before, this is one example of some of the other tissues. For example, immune cells like monocytes and macrophages use calcitriol to modulate their function, and it's been shown that this can help prevent autoimmune disease and help us fight invading pathogens. Other tissues like prostate, breast, colon, lungs, skin, we find that they all use calcitriol to regulate cell growth and differentiation. And that imbalances in calcitriol levels or storage form vitamin D levels can impact cell growth and differentiation and cancer incidence. And we'll talk more about cancer soon. So we're having local production of calcitriol all over the body in various tissues. This is actually old. This is from 2003. I didn't get a chance to update it, but there's a new article that showed that there are over 200 different genes in the body that are triggered by vitamin D. So vitamin D is a steroid hormone. It passes through the membrane of the cell and it stimulates a nuclear receptor, a vitamin D receptor, that affects transcription of more than 200 different genes, very different functions all over the body. So here's a little diagram of the vitamin D receptors, of the receptor, again a nuclear receptor. An example of some of the types of tissues we find in it: widespread pancreas, monocytes, so you get these immune cells, neurons, glandular cells, organ cells, connective tissue like endothelium and skeletal muscle and bone, of course. As I mentioned before, calcitriol levels are directly related to parathyroid function. And we can actually start to see parathyroid hormone increase when vitamin D storage levels are in the range of 30 to 40 nanograms per milliliter. Now, most labs that we use have set their cutoff for vitamin D deficiency or insufficiency at 32 nanograms per milliliter. And that seems to make some sense, because if your vitamin D level is getting so low that parathyroid is going up, you probably have some physiologic need for more vitamin D. We know that parathyroid hormone is associated with positive health outcomes when it's low, such as lower risk of heart attack, hypertension, and stroke. So it's a good thing to have low parathyroid hormone, and that might have to do with calcification of the endothelium. So when reviewing vitamin D studies, beware of a few factors. Are we talking about vitamin D2 or D3? A lot of the older studies don't even mention what form they're using, so that becomes difficult to evaluate the results. The storage form of vitamin D is often expressed in different units. Nanogram per milliliter, more common in the US, but sometimes you see it in nanomoles per liter. Those are not equivalent, so keep that in mind. Some of the older vitamin D studies use cod liver oil for their source of vitamin D, which doesn't make a lot of sense. It has a lot of vitamin A in it, and A and D compete for absorption, so I'm not sure what's getting absorbed and it's just not a preferable form of vitamin D for a study model. Also, baseline vitamin D status makes a huge difference. You'll see these great results in the studies that are treating vitamin D deficient people, and you'll see less impressive results in treating people that are already replete. And of course, that just makes sense. But I would argue that most of our patient population is insufficient or deficient. Dosage makes a big difference, and you'll see this in the studies that I review. Association versus causality, just a reminder, a lot of these are epidemiologic studies. Let's not assume causality, but there is some pretty strong evidence here in the association. And then very, very few of the studies talk about vitamin D cofactors. These nutrients, magnesium, vitamin K, zinc, and boron, things that our patients are sometimes deficient in. And without these nutrients, the action of vitamin D is going to be impaired. So that would impact study results, but it's rarely mentioned. And we'll talk more about this toward the end of the conversation today. So let's get into old news, vitamin D. This old news is very exciting, even though it's somewhat old. Let's look at vitamin D in heart disease. A review from 2008 of 1,700 individuals. They had their vitamin D level measured, and they were followed for 5.5 years. Compared to the group that had greater than 15 nanograms per milliliter. So the highest vitamin D level in the study is still, by our standards, insufficient or deficient. But when you looked at the lowest group, they had an 80% increased risk of having a cardiovascular incident over 5.5 years. And that mid-range group, 10 to 15 nanograms per milliliter, had a 53% increased risk. So a very moderate, very small raise in vitamin D levels over those 5.5 years was associated with a huge difference in outcome for cardiovascular disease. And the authors concluded vitamin D deficiency is positively correlated with incident cardiovascular disease. Another look at cancer, very impressive. Sometimes when I'm looking at these studies, I'm thinking, what would happen if a pharmaceutical agent came out that could purportedly lower our risk of heart disease by 80% in 5 years? And I think it'd be a big hit. Cancer, close to 48,000 men in the health professionals follow-up study over 14 years found that a 10 nanogram per milliliter rise of vitamin D, which isn't a huge rise, was associated with a 17% reduction in cancer incidence, a 29% reduction in all cancer mortality, and a 43% reduction in GI cancer mortality. I mean, that is huge over 14 years, just a very small rise in their storage form. So, if there was something we could be giving our patients that might prevent close to half of GI cancers, I think we would probably do it. Pain, a study from the Mayo Clinic looking at 150 people with persistent, non-specific musculoskeletal pain. 93% of them had vitamin D deficiency. That's a lot. Another study looked at close to 300 low back pain patients and supplemented them with 5,000 to 10,000 units of D3 daily. And nearly 100% of those patients decreased their use of pain medication over 3 months. So if there was something safe we could give to our patients that would help decrease their reliance on pain meds while improving their likelihood of cardiovascular health and cancer prevention, we would probably do that. Type 2 diabetes. Metformin is known to improve insulin sensitivity by about 13%. In this study from 2004, American Journal of Clinical Nutrition, they found that people with the highest levels of vitamin D were associated with a 60% improvement in insulin sensitivity compared to the lowest group. Also, a small trial of 10 women with type 2 diabetes given 1,332 units of vitamin D for 30 days had a 21% increase in their insulin sensitivity. So a stronger effect than metformin from what I consider still too low of a dose of vitamin D over 30 days. Pretty powerful. I think that most of our diabetic patients in Midwinter and Maine could benefit from vitamin D. Maternal fetal health, and this might be one of our possible treatments that can really help the health of our population. I always love focusing on maternal fetal health and prevention because it can make such a big difference in people's lives and families' lives. So in Boston, a study looked at 253 pregnant women over 2 years in their hospital, And they found that women who had less than 15 nanograms per milliliter of vitamin D in their blood were more than 4 times likely to have a C-section compared to the group of women that had more than 15. So they just drew this line at 15, above and below, 4 times more likely if you were below that line. And women who had the highest levels, above 50 nanograms per milliliter, which is, it happens to be the physiologic level where a woman who's lactating can make enough vitamin D to prevent rickets in her kid. That's somewhere around 50 nanograms per milliliter in most women. So a physiological sign that that's probably where we ought to be. Also, equatorial patients that get a lot of sun usually have this much in their blood, somewhere in that range. So it's a pretty normal level. They had 5% of the total C-section rate of the rest of the group. These are just really impressive numbers to me. Epilepsy is an interesting topic in vitamin D, and a lot of people don't think about it. But seizures can actually be the first sign of vitamin D deficiency. And having low vitamin D will decrease the seizure threshold. And kind of paradoxically, several anticonvulsants can interfere with vitamin D production, actually with calcitriol production. They can induce hepatic clearance of calcitriol, impair calcium absorption from the intestine, and mobilization from the bone, and can actually cause iatrogenic seizures via iatrogenic hypovitaminosis D and hypocalcemia. So it's something really to think about in our patients with seizure. What's their vitamin D status? Longevity, something that's important to a lot of us. A meta-analysis of 18 randomized controlled trials with over 57,000 patients. The range of vitamin D dosage was 300 to 2,000 a day, not a whole lot. The people that had the highest vitamin D intake had a 7% reduction in all-cause mortality. The authors concluded in 2007, based on the total body of evidence of health conditions associated with vitamin D deficiency, abetted with the results from this meta-analysis, a more proactive attitude to identify, prevent, and treat vitamin D deficiency should be part of standard medical care. That's what I'm bringing to you today, if it's not already part of your standard medical care. So that's the old news. Very impressive to me. Here's some new news that I also got extremely excited about. Fracture prevention. This was a New England Journal of Medicine review of 11 double-blind randomized controlled trials that came out in 2012. 31,000 patients. Mean age was 76. 91% of them women. The highest intake level of vitamin D in these studies was 800 units a day. So a very small dose of vitamin D. 800 units was associated with a 30% reduction in hip fracture and a 14% reduction in the risk of any non-vertebral fracture. We know hip fracture is a major cause of mortality in the elderly. If we could prevent that by 30%, I think we would. Vitamin D and mortality. A study of 9,000 individuals from 1993 to 2009 looked at their vitamin D levels from the beginning of their enrollment and looked at those who died, and then split the group into 4 quartiles based on their baseline vitamin D levels. So up to 9 nanograms per milliliter, up to 16, make that 10 to 16, 17 to 22, and 23 to 32 nanograms per milliliter. Or actually, I think that's not. I think it's above 32 nanograms is the highest quartile. But when they compared the 4th and the 1st quartile and looked at all, at these various major causes of mortality, it was found that the highest vitamin D group compared to the lowest vitamin D group had about a quarter of the risk of dying from a respiratory system disease. Had 0.28% the risk of dying from a digestive system disease, and had 0.2 risk of endocrine disease death. Unlike most other studies, they did not find an association between vitamin D status and cancer death. And that might be because their highest quartile started at 32 nanograms. If it had maybe started at 40 or 50 nanograms, we'd probably see some cancer results here. But we already saw those old cancer results that were quite impressive. A randomized controlled trial on depression, giving people Prozac or giving people vitamin D and Prozac. This was 42 patients with major major depression. 95% of them were insufficient at baseline. After 4 weeks, the vitamin D and Prozac group was significantly better than fluoxetine alone. Yep, so that's after 4 weeks. So vitamin D on its own, I think, helps with depression. I see this in my practice all the time. I think it can augment the effects of other antidepressant treatments that we're doing, all while having these wonderful positive side effects, these wonderful benefits. Persistent nonspecific musculoskeletal pain. 84 immigrants from the Middle East, Turkey, Northern Africa, and Somalia that were living in the Netherlands, aged 18 to 60 years, got 150,000 units of D3 at baseline, and then again at 6 weeks. At 6 weeks, the vitamin D group reported significant improvement in pain. The vitamin D group, 35% of them had improvement in pain. Placebo, 19% had improvement in pain, which I love this. 19% improved their pain when they were just given a placebo. It's also very powerful, something to remember. And also at week 6, there was a significant difference in their ability to walk stairs. 21% improved in the vitamin D group, 8% improved in the placebo group. So persistent nonspecific pain seems to respond well to vitamin D, especially when people start off deficient. Hepatitis C. This is extremely impressive. 72 patients with genotype 1, which is notoriously difficult to treat, were either given standard therapy or standard therapy plus 2,000 units of vitamin D. 2,000 again is a nice but not huge amount. The control group received identical. Let's look at the results. At week 4, 44% of the patients who received vitamin D were virus-free, and 17% of the standard treatment group were free of the hepatitis C virus. At week 12, 94% with vitamin D versus 48% without vitamin D, standard treatment alone. And at 24 weeks post-treatment, which is kind of the goal where we assess was this treatment successful, 86% of the vitamin D group was successful, while only 42% of the standard treatment group was successful in getting that virus into remission. This is huge. If anyone has a patient that's undergoing hepatitis C treatment, I would make sure that they're getting vitamin D along with their standard therapy. And this is starting to become more common in general practice in gastroenterology and infectious disease. These are just bar charts showing those numbers. This was the end result, 86% versus 42%. Then the same authors were wondering, does this also apply to the other genotypes, genotypes 2 and 3? And we got similar improvement in the vitamin D treated group, 95%. Of course, better improvement in the standard therapy group, 77%, because these genotypes usually respond better to standard treatment. But still, 77 to 95 is significant. So even with genotype 2 and 3, getting treatment for hepatitis C, put them on vitamin D. And the question I have is, what would vitamin D do for these patients if they weren't receiving standard treatment? Maybe they would get better also. Who knows? Respiratory tract infections. 4,000 units of vitamin D3 for a year, and 140 patients that had frequent respiratory tract infections. 60% of them were known to be immunodeficient. The other 40% just had more than 4 bacterial infections per year. The treatment group that got the vitamin D, 4,000 units a day, 25% reduction in self-reported infections, and 64% reduction in antibiotic use. So that's really significant. Give 4,000 units a day and we end up giving less than half the antibiotics to these patients that use them quite frequently. They concluded that vitamin D supplementation reduces the odds of taking antibiotics by approximately 60% in patients with frequent respiratory tract infections, and that it could provide a novel strategy for reducing antibiotic use, which of course is important because of the emerging epidemic of bacterial resistance. So whenever we can find something that reduces antibiotic use, especially in these patients who use it all the time, it's really important to public health. Again, vitamin D is a major key that we can use to improve the health of our population. Also, pneumonia death. If any of you have a patient that gets admitted to the hospital with community-acquired pneumonia, their vitamin D status at admission is predictive of whether they'll live or die in the hospital. And it's actually, when you add that variable to a standard mortality prediction scale like the Pneumonia Severity Index, the accuracy of the Pneumonia Severity Index improves. So vitamin D is quite predictive. So if you do have a patient that goes to the hospital for pneumonia, it'd be great if their vitamin D level was high before they got there. They'd be more likely to live. Infant heart failure. These are really sick children. 80 infants with CHF given either all the conventional treatment plus 1,000 units of D3 daily, or simply the conventional treatment with placebo. The ejection fraction in the vitamin D group went from 36 to 52, and the other group without vitamin D from 37% to 43%. So we doubled the improvement in their injection fraction by giving 1,000 units of vitamin D. Their serum had less of these inflammatory markers, which is a good thing. And the authors concluded vitamin D supplementation has great benefits as anti-inflammatory agents in infants with CHF. It helps acceleration of the clinical improvement and cytokine profile balance. Now, if it's doing so much for these really sick kids, I think there's probably a lot it would do for the other babies as well. Atopic dermatitis, 60 patients with no systemic disease receiving 1,600 units of D3 daily for 60 days versus placebo, two different scoring systems. The vitamin D group went from a 24 to a 15 versus placebo went from a 25 to 23. So minimal change in placebo, significant improvement in vitamin D. The other scale also showed significant improvement. And interestingly, this improvement was associated with very moderate elevation in their serum level of the storage form of vitamin D. So going from a 9 25-hydroxy-D to a 22 gave significant improvement of eczema. I think their improvement would have been even more if we had gotten them up to the 40, 50, or 60 range here. And I see this in my practice all the time. I use vitamin D to treat eczema. It often doesn't resolve it completely, but it usually improves it quite significantly, more so in the people that are the most deficient. Lupus, difficult to treat. 267 patients with lupus given 2,000 units a day or a placebo for 1 year. Their average baseline was deficient at about 20 nanograms per milliliter. After 12 months of therapy, the vitamin D group increased to 37 nanograms per milliliter, no change in the placebo group. 10% of the patients in the vitamin D group had a flare-up, while 24% of the patients in the control group had a flare-up. So we cut flare-ups down by quite a bit, and the authors noticed a reduction in lupus-related antibodies and concluded that vitamin D is safe, inexpensive, and may be as effective as disease-suppressing interventions for patients with lupus. I just want to do a time check. Anyone got the time?
12:35.
Great, thank you. D2 versus D3. So this is an important topic. D2 is ergocalciferol, D3 is cholecalciferol. And you can see over here the molecules are very similar. D2 is plant-based. It's we take ergosterol from fungi and irradiate it. It's commonly known as Bristol. Many of you have probably prescribed Bristol. Vitamin D3, cholecalciferol, animal-based. Most of the supplements come from irradiated lanolin. So they take the oily excretion from the skin of the sheep, irradiate it, turns into D3, has a pretty good shelf life. D3 is not FDA approved, which is interesting. It is actually FDA approved when it's combined with alendronate, but it's not approved on its own. And a lot of resources that you'll read suggest that D2 and D3 have equivalent activity in the body. So I wanted to look into this. Also, most insurance plans cover D2. So one study I found that looked at 30 healthy men, 10 in each group, and they were either given 50,000 units of D2, 50,000 of D3, or a control. And what we found was equivalent absorption, a similar initial rise in their storage form levels. But what happened in the D3 group is the rise in the level continued out, and in the D2 group it dropped right back down. Here's the graphic. So here's storage form of vitamin D, days on the bottom up to 30 days. And we have the D3 group, their level went up and it kept going up, and then it started to go down. It peaked at 14 days, but the decline was gradual. Giving someone vitamin D2, they peaked at 3 days, and by 14 days, they were back at baseline. So D2 is not very efficient at keeping people's serum levels up. And I've spoken with rheumatologists that are using Bristol and don't get the results they hope to get. And I think it's just because the serum levels, it's just really hard to get people's serum levels above 30s and 40s if you're using D2, unless you're using a lot. And we don't really know much about the byproducts, the metabolic byproducts of high doses of D2, but it's probably not as safe as using lower doses of D3, which would be more effective. So in summary, these authors from a 2006 article stated that D2, if given in high enough doses, can prevent rickets and promote healing of osteomalacia. But it basically has 1/3 to 1/9 the potency of D3. And that's figured out by looking at the area under the curve. So in 30 days trial, the area under the curve of D3 was 3.4 times what it was for D2. But if you calculate the area under the curve as it goes out to infinity, it looks like D3 is actually about 9 times as potent as D2. So 9 times as potent. Not sure why it's not FDA approved. Maybe there's a reason. They concluded D2 should no longer be regarded as a nutrient appropriate for supplementation or fortification in foods. But this is still what we prescribe for our patients in a lot of settings. It's what insurance covers. So let's talk about vitamin D toxicity. Different opinions coming from different sources, so I wanted to kind of give you a variety, and then I'll tell you what I've seen in my practice. Maybe some of you, if you have stories of vitamin D toxicity, can share. There is this from American Journal of Clinical Nutrition in '99, suggests that there's no credible evidence for toxicity at levels below 150 nanograms per milliliter, no evidence for toxicity at a dose of 10,000 units a day indefinitely. Merck Manual, published in '87, a little more conservative, and the serum levels of storage form of D. They found that there was toxicity when the level got to be 90 or greater. I've seen more than 90 with normal calcium levels at. So maybe this is true in some patients. But this same source also stated that toxicity is rare and requires long-term administration of at least 40,000 units a day in infants, or 100,000 units a day in adults for several months. This was probably talking about D2, but still 100,000 per day for months required for toxicity. So while we can have toxicity in vitamin D, it's going to be pretty hard to get there. You have to really make a mistake in dosing, which, by the way, happened to a somewhat controversial alternative medicine educator and writer named Gary Null. He was taking his own supplement product, which the manufacturer put in the wrong amount of vitamin D by 2 orders of magnitude. So instead of getting 2,000 units a day, he was getting 200,000 units a day. And he did get elevated calcium and calcification of his kidneys, and he got really sick with that. So it is possible. This can be toxic if it's given in too high of a dose. But like I said, it'd have to be a big mistake to get people to those doses. Another source from 2001, American Journal of Clinical Nutrition saw toxicity symptoms with levels greater than 125, anorexia, nausea, vomiting, weakness, nervousness, itching, thirst, renal impairment, calcifications in the soft tissues. What's interesting is most of these are the symptoms that they were looking for, actually titrating the dose of vitamin D2 in that study from 1939 that I showed. They were giving people enough D2 until they developed these symptoms and then stabilizing their dose. Thank you. Please be careful in patients with sarcoidosis because the macrophages, as we saw earlier, convert the storage form to calcitriol, and they have a lot of these macrophages, so it's possible to get toxicity with much lower levels of vitamin D supplementation in sarcoid patients.
How long are you talking about?
How low?
Toxicity, yeah.
Um,
Sarcoid thing.
Yeah, I think it probably varies by patient, so you would want to measure 25 and 125 dihydroxyvitamin D carefully in those patients. Safety in pregnancy. So a human study with 15 pregnant women that had hypoparathyroid. They were given 1,000 units of D3 every day in order to keep their serum calcium levels up. And then their infants were followed. Their infants showed no abnormalities, had normal vitamin D levels when they were born. They were followed out for 4 years. So 100,000 units a day sounds like a lot in pregnancy. The babies were still okay, from what we can tell. Prevalence of vitamin D deficiency, it's huge. Overall prevalence rate in the National Health and Nutrition Examinations Survey 2005 and 6, 41%. That goes way up in blacks to 82%, 69% in Hispanics, and it's more common in those with no college education, obese patients, poor health status, hypertension, and so forth. This is very common, more so in Maine. If any of you have a patient that's not supplementing vitamin D or not going to Florida or to an ultraviolet B tanning booth, right now, next week, check their level, they're going to be deficient most likely. Benefits of sun exposure. We need to rethink this a little bit, I think. This was a study done in the Netherlands, or actually, I'm not sure, one of the northern European countries, that looked at all the data they had in their population for sun exposure, ultraviolet exposure, incidence of malignant melanoma, and then also the data around vitamin D and cancer prevention. And what they concluded was, if they could raise everyone's level of vitamin D by 10 nanograms per milliliter, conservative rise, they would increase 200 to 300 deaths from melanoma every year, which kind of sounds like a lot until you think that they're actually preventing 10 times that in other types of cancers. And this is something that's been looked at a lot. People who get skin cancer are often less likely to develop primary internal cancers. Maybe it has something to do with vitamin D. So we're telling our patients to put on the sunblock and avoid the sun exposure to prevent melanoma. We may be actually hurting them with that advice, increasing their risk of cancer, unless we're intelligently supplementing their diet with vitamin D. So what I recommend to my patients, protect your face and eyes, expose your skin to the sun when the sun is high in the sky, because then you're able to get vitamin D at a lower percentage of your minimal erythema dose. So you can get out there for 10 minutes and not burn, come back in, and you've made your vitamin D for the day. Avoid sunburn. I mean, really simple. When it hurts and turns red, we've probably had too much. So just listen to your bodies when getting sun exposure. Avoid washing the skin with soap after exposure. Not a lot of people think about this, but the vitamin D is produced and then it has to be absorbed into the blood. If you wash with soap, you're actually going to wash it off before it can get absorbed. And finally, use more skin protection early in the season so that you can have a chance to tan and build up your melanin levels and protect yourself from the ultraviolet exposure. These are my recommendations for patients. My goal for patients is to get them to 50 to 100 nanograms per milliliter because it's safe, they're not toxic in that range, and they receive the best health benefits from what I can observe clinically. And it's global change. It's less pain, better mood, more positive, more energy, better flexibility. I mean, it just goes on and on. Whatever their issue is, it seems to get better. Testing in the early winter makes the most sense, but you can test any time of the year, and you'll be surprised how many people are deficient in the summer. Remember to check calcitriol levels in patients with kidney disease and, of course, sarcoid. Retest after 3 to 4 months of supplementation to determine if your dosage estimation was correct. We see that people on the same dose for 3 to 4 months, their blood levels usually stabilize. So here's my dosage recommendations. 1,000 units of D3 for every 30 to 50 pounds of body weight, depending on body fat percentage. So for the more obese patients, we're looking at 1,000 for every 30 pounds of body weight. For the more slender patients, 1,000 units for every 50 pounds of body weight. This seems to get people into that range. Empiric treatment of adults with 4,000 units a day is safe without monitoring. So if you can't get patients to draw blood, just give your adults 4,000 units. You're going to really improve their health outcome. In severely deficient patients, consider a loading dose of 10 to 20,000 units a day for 1 to 2 weeks. I do this because it gets people's levels up quickly and because they fall in love with this stuff. They take that 20,000 unit dose and they feel so good that same day, just a couple hours later. Oh, I had so much energy, my thoughts were so clear, I felt so great. And then they're more likely to adhere to your treatment plan over time. D3 can be taken once a week for convenience. A lot of the studies do that. It's fat soluble, stored in the body, so they don't have to take it every day.
So how much, when you do it once a week, what do you give them then?
Yep, same dose. I would do, 4 times 7 or whatever you came up with. Same total dose. And sun tanning. I have a lot of patients that love the feeling of going to the tanning salon. They just feel good afterwards. So to them, I have them make sure that they're getting ultraviolet B. There's different bulbs. Some can make A, some make B, some make a mix. So we recommend ultraviolet B bulbs and simply avoid overexposure. When you go in there, don't get burned. I'll get to your question. I'm just about done, then we'll come back to you. Recommendations. Think of vitamin D in these populations, but really think about it in everyone. I mean, so many of our most common conditions will respond to this stuff. How to prescribe vitamin D. This is what I do. I would consider selling D3 in your office because it's hard for patients to find sometimes in a truly economical form. This is what I do, the best deal I could find. Wholesale price on this bottle, $10. Here's the website, retail $20. We sell it for $15. One drop is 2,000 units, and each bottle contains 900 drops. So very potent stuff. One little drop, 2,000 units. This is a year's supply for most patients. They can get it for $15. Something like that is something that your patients can really benefit from. This is a public health campaign here that can really improve the health of our population. Briefly, vitamin D cofactors. Clinically, the thing that's the most important here, I think, is magnesium. I see people that get on vitamin D, their levels come up, they're doing great. They come back 6 or 12 months later, and they've got this hypertonicity in their muscles that you can palpate, and they're complaining of cramps and so forth. And what the vitamin D is doing is using magnesium for bone remodeling and bone formation, and that makes the magnesium less available to some of the other tissues. You put them on some supplemental magnesium, and these muscle cramp and hypertonic issues go away. So it's and you know, you can also find zinc boron K2 deficiencies in patients, and those things are important for vitamin D metabolism. Just about done here. Thank you all for your attention. Vitamin D has a wide spectrum of physiologic activity in various tissues and is associated with our most common health conditions. It has direct and short-term benefits on chronic pain, autoimmune disease, depression, and much, much more. It is most likely the cost-effective preventative health measure for any person in the winter in Maine. Thank you very much, and I'll take some questions. One in the back is the first one.
Yeah, so like a two-part question. These studies have shown that the positive results with the vitamin D supplementation, was it vitamin D2 that was used, or was it vitamin D3? And the fact that the vitamin D3 stays longer in the bloodstream, can't you potentially imagine that the D2 is actually used more readily by the body, and that's why the level drops quickly, while the D3 is maybe not used as readily and stays around the bloodstream longer?
It's a great idea. Maybe the reason D2 drops faster than D3 is because it's used more, but actually it just has a shorter shelf life. It has a shorter half-life. It's a less stable molecule. So I think it self-degrades faster. And in the study, hopefully you'll have access to the slides, I tried to indicate whenever a study would say D2 or D3, which one they were using. That study that looked at 3 to 4 months of a constant dose and people's blood levels plateauing, that was D3. So I think that still applies. I think we'll go back here.
Were there any studies on oral health and dental outcomes? You know, it's a big problem here in Maine, as we all know.
It's a great question. There probably are. I didn't review any when I was preparing for this. But it's an excellent question. Thank you. Maybe something we can look into.
There are quite a few dental health. A lot of the dental hygienists really preach vitamin D.
Okay.
I want to thank you for an excellent lecture. There was one caution that I didn't hear about, which is in the elderly, vitamin D binds to plaque. So it is a dose-limiting concern.
Okay, so the two comments made for those that didn't hear, one is that there certainly are vitamin D studies on dental health that show positive effect, and the other comment was that vitamin D binds to plaque in the elderly. I didn't come across that, I'm not sure. Any other questions? Yep, there's one back here.
Are all over-the-counter vitamin D3s equivalent?
Probably not. It's really unregulated, unfortunately. So we don't know if all vitamin D supplements over the counter are equivalent, but I imagine that the cheapest one on the shelf might not be as trustworthy as a more extensive product. It's just unregulated. Great question, though. Sure, back here.
Since you're talking about vitamin D, when you look at calcium with vitamin D, 2 major studies have shown increased intimal calcific atherosclerosis in women who took calcium supplements as opposed to women who did not. Framingham Heart Study showed it, so did the New Zealand Heart Study. Are you recommending calcium with vitamin D? And if so, how do you talk about that in that circumstance, especially with aging people?
It's a great question, and I didn't include it because we don't know that much about it now, but I'll tell you what I have come across. The question is calcium supplementation alone, calcium and vitamin D, or just vitamin D, and bone health, intimal atherosclerosis related to calcification. So what we find is giving calcium on its own isn't as effective in promoting bone health as giving vitamin D alone. So that's one thing. Also, it seems like vitamin K2, or vitamin K in general, but K2 especially, has a lot to do with the calcium utilization. So while the vitamin D is increasing the calcium resorption and absorption and so forth, without vitamin K on board, it's not going to be used as efficiently in bone remodeling, which would then increase the risk of cardiovascular complications potentially. But I don't supplement my patients with calcium alone ever. I often recommend people taking vitamin D, take a multi-mineral supplement with equivalent levels of calcium, magnesium, and then an array of all the other trace minerals.
And I don't recommend calcium either, by the way, for the reasons of those two major epidemiological studies. Thank you.
Great, thank you. Well, thank you all so much. This is my
Before everyone bails out.